Welcome to part 2 of examining the anterior approach from down under. Let's get back to our conversation with Australian hip surgeons Patrick Weinrauch, Ilan Freedman, and Jit Balakumar, as well as orthopedic sales rep Joe Scerri. Which just kind of raises my next question. So, and you sort of started this conversation here a bit, Jit. So what do you guys see as the biggest challenges or controversies about DAA within the landscape of Australia?
The biggest controversy, it's what you've said already. I think the creme de la creme in orthopedics for most hip surgeons is arthroplasty. You know, you have a winning surgery, very predictable outcome. Patients are usually low maintenance, so that's what most people want to do. And so I think you have to be careful. There's the private practice aspect, and we've all seen LinkedIn videos, YouTube videos of patients walking day one post-op, 20 steps of stairs. And, you know, this is the marketing, right? And I think it's not dissimilar to what my senior colleagues did with the yellow pages. So we shouldn't criticize people for that. With it comes some risks because we all get complications and we all have problems. So when you put yourself out there, it can also be the sword you die by, right? But let's look at the data. The data shows the anterior and posterior approach is exactly the same in outcomes at 6 months. And, you know, there's double the rate of dislocations with posterior approach, almost 3 times the increased rate of infection, but twice the rate of fracture and loosening, early loosening in the anterior approach. So there's, you know, trade-offs. And I think we have to be cognizant when you do it. But I agree with Dr. Marta completely. I think the current market is very, very astute. They know what they want, and they are all on social media. You know, Pat does a lot of resurfacings. I have so many patients coming in saying, look, I want a resurfacing. And I said, where did you hear about this? They go, I'm on a Facebook website. I'm a runner. I'm a marathon runner. I've heard that you got to be loading your proximal metaphyseal bone if you want to run long distances. And and I said, look, you're absolutely right. Look, I'm going to send you to one of my partners. But the market is way more well equipped to actually know and have the knowledge than we give them credit for. I think gone is the paternalistic era. But you've got to play a role in this and say, look, I think in my hand, this is what the best approach is. So I think Dr. Marta's absolutely right. The market's driving it, and that's what's going to organically grow it.
Do you think we're moving the paternalism out of the clinic room and onto the internet when we're engaging with patients that way? I mean, is that we're sort of seeding that information a little bit to our patients ahead of time?
Yeah, it can be a bit difficult. Patients coming in now, you know, asking for specific bearing surfaces or asking you about particular polyethylenes or which exact metal have you used. So I guess it's the side effect of having all this information on hand. Patients can access all of that very easily, and many of them do. So they come in with good questions, but sometimes come in with questions which they don't really know what to do with the answers. You know, they come in asking, well, what metal is it? And you tell them and they look stunned. So but I mean, people are coming in, you know, very informed, and they've read your bio, they've read your results. In some cases, they've read your papers. So I guess that's the reality now.
Well, I don't mind patients being well informed. You know, I think that I think that it's good that there's sort of, you know, we instinctively, I think sometimes they're maybe a little over informed, but you know, there's a good balance there, and I think you know, I think it's nice to be able to have a really robust sort of education of a patient prior to their surgery. So I don't sort of shy away from, you know, a patient comes in and my heart doesn't sink when they come in with their ream of papers. You know, it's like, yeah, sometimes it can be a bit tricky, but you know, our role as a responsible professional is to guide them, right? And so, you know, we're there to be able to educate them and to be able to put what they've read into context and balance, because like we're the subject matter experts, and if they're relatively well read, then it's actually quite easy to direct them there and to be able to give them a framework to be able to understand what they're reading. And I suppose my comment, bringing it back to anterior approach, is you know, that, I mean, historically, I think when anterior approach first came into Australia in any numbers, there was very much it was really marketed hard. That wasn't necessarily just, in fact, that probably wasn't so much surgeons who were driving that. That was industry. So industry was driving anterior really hard because there was one company in particular that was linking, you know, sort of anterior approach and this is the implant and this is the table. And so it was like a package. And from a surgeon's perspective, that was the easiest conduit to be able to get education in this space as well. So it was a very, very successful marketing strategy to be able to educate surgeons, educate the community, and build awareness around it all simultaneously. And so that particular company, which was really a minnow in Australia at the time, has really boomed, right? So it's a very successful company now in Australia for that reason. I think we've seen a bit of a correction now over the last sort of 5 to 8 years where pretty much all of the companies have got an anterior offering now. So instrumentation platforms and things like that. And so, so we're now starting to see a bit of diversity amongst the ways in which we are doing surgery. For instance, whether it's being put on a traction table or not on a traction table is I'm not sure we can't capture that on the Australian registry. My instinct is it's probably still dominated by table use, but then there's quite a component which are doing it off traction tables as well now, which is pretty much and very much being implant agnostic now as well.
Would you say that the industry-based education that you're talking about, was that a primary driver towards adoption of anterior approach, or were people getting their surgical education on this technique mostly in other ways?
So in Australia, like when I went through my residency, we call it registrar, but residency, there was really no exposure to anterior approaches. So this is a technique that I've taken up post qualification fellowship. And so we're very reliant on industry support to be able to get that education, right? Unless, of course, you do us nowadays, if you can find a place to go and do fellowship, right, where you can learn those techniques in your fellowship. But, you know, a post-fellowship orthopedic surgeon requires industry support. The industry is still very involved here in Australia in surgeon education, not just an anterior approach, but in all aspects, you know. So
I run 2 fellowships, and all my fellows, they start their practice. I have a local fellow and an international fellow, and their practice almost instantly explodes because of anterior approach. Look, obviously I learned slightly differently, but I remember that actually the first anterior approach I saw was with a guy in Box Hill Hospital, public hospital. And there was 2 of them actually there. One guy who did it on the table, supine, and another guy who did it in the lateral position anteriorly. And I was blown away by it. No one talked about it. There was no marketing, but their recovery was very different to the rest of the unit. And then when I went to my equivalent rural rotation, I convinced my boss there to do it anteriorly. We had a ASR head with an ASR cup with a Zweimuller stem, and it was a disaster. And I should never have convinced my boss to do that. But I would say, look, I echo Pat's points. It's changed very much, and the industry has really been, you know, people are very quick to criticize industry. They have improved patient outcomes dramatically by championing high quality education, right? And you know, the smaller startup companies use it as a point of difference. The larger companies try to get ahead with it. And now, you know, often they'll fund fellowships that are attached to an anterior because they can see the return on investment and how they can monetize it, right? On the flip side, I think every hospital, I'm sure it's the same in Queensland, in Australia, in Victoria, to be credentialed. So they classify anterior hips robotic surgery as a tier B credentialing. So not the standard that you finish in your training program. And to be credentialed, they expect you to have done either a fellowship or have done at least 30 cases with someone who's an experienced anterior hip surgeon and then be supervised by their local, whoever the hospital representative is. So there's some very robust credentialing process. And I, again, tell trainees, look, you've got to be careful when you first start. You don't want to you've got to slay a few dragons to get your princess. And we don't want to go through that process, right? We don't want to be slaying dragons. That's not the process with this. And I think industry has done that amazingly here.
Joe, as the representative of industry in this conversation, I mean, what have you seen in the landscape of anterior approach in Australia? Or what has been most striking to you?
I think I'd like to answer that question a little bit historically, and that is in a lot of the points that the guys are making. Certainly, fellowships are really important, and I've done a number at Wrightington and various places like that over the years, in France and so forth. And they have been, as has been mentioned in terms of the return on investment, excellent, because quite often they're with a high volume surgeon who happens to be using, obviously, the implant that is manufactured by the company that sponsors it. And then they come back as a devotee, and, it becomes a nice circular return. Everybody wins. And so that's been a worthwhile investment. As far as I know, most companies continue to do that. Then you've got the existing fellowships, the one that you've mentioned, Jit. Well, when Jit does the anterior approach, the people that become proficient at that have to learn somewhere. So if they decide that's for them in their private practice, then they'll continue to do that. So that goes on. And then you've got, people like Pat who do visitations from various companies. And I think that there are selected people around the country who perform direct anterior where there are medical companies that will send surgeons to those surgeons, because it enables them to be trained on the anterior approach. But at the same time, presumably, if they like the implant at the time, then they go back and that becomes part of their private practice. And I think that's where, one hand rubs the other, and everybody wins as well. And, then there are other things that, I'd like to get involved in, and that is, we're not big enough to be able to sponsor those things, but certainly things like cadaver workshops, where, that can be learnt on that approach. I think, those go on as well. But I think the combination of fellowships, visitations, and certain workshops are probably the collection of things that surgeons are getting exposed to, and registrars and senior fellows.
Has the landscape for visitations in Australia, has it begun to include things like reverse site visits where a mentor will come and spend time with a surgeon as they're starting to do their cases? And has there been any introduction of sort of virtual visitations using augmented reality, virtual reality, those sorts of things?
I've got to say something about that, though. Look, I do have a problem with visitations, and I think Pat and I were with J&J at this stage where they were trying to develop this mini fellowship in visitations and reverse visitations. So I do think, all of our pet interests is adult education, right? And adults are very differently educated based on who you are. There are some who can just do that and they'll come back. And I'm sure, Pat, you've probably taught a lot of people how to do resurfacings, but there are some you would never let do a resurfacing afterwards just by watching you. And some of these things require a lot more. So you want the expert novice right at the end of that visitation. And that's not what you're getting, I don't think, with anterior, who've never had it before. So it's probably different for the next group of trainees. But I think that was one of the downfalls of the anterior early on, was there was high fidelity training on cadavers. Then you came and saw someone, but they weren't the expert novice. They weren't the airline pilot who's done 10,000 hours on the simulator, right? They were essentially still going through their learning curve. And hopefully, so I do have a problem with visitations and reverse visitations for certain surgeries. And I think anterior approach is one of them. I think it has its place at a certain stage, not early on in their learning curve. But it looks, everyone's different. There are some people who are exceptionally talented and they'll be able to do that very easily, right?
I mean, I see people at various points in their learning. And so, they might come up and visit to be able to see a bunch of cases being done just to be able to know, actually, is this really a thing? Is this something that I would even contemplate bringing into my practice, or, is there something that, it doesn't stack up for me? And then they see it and they can make their decision, right? And then they might go off and they might start learning a bit more, and they might go and see another guy. And what I tended to observe in that space, though, is that they would sit in a pre-learning space or a learning space, but they'd never actually start. It would be like the conversion on that conversion into starting doing their own cases was a bit of a rocky, sort of transition. And that's where, having a high quality, longer fellowship, I think, has the benefit, because there's a lot more sort of guidance in that transition zone. And to try to bridge that with a reverse visitation is sometimes difficult, because it's one day, we've only got a couple of cases. Yes, it is. You have got an expert surgeon with you, but it's not like doing it for over a period of months, right? And reverse visitations for us are they're difficult, because you've got to get licensure and accreditation in the receiving facility. And it's very, very time consuming as well. If it's just a guy down the road, that's pretty easy. But if it's like, we're a big country, right? So to fly, 3 or 4 hours to go and do a reverse visitation is sort of like a 2-day process, right? So could we use technology to be able to help that? I think absolutely there's a space for that, right? So having the remote expert with, like we've talked about, like Google Glass or, equivalent sort of devices where the remote expert can see what the surgeon is doing. Is that a bridging tool? The answer is yes. Is it, I suppose, if we rated things on the scale of minimum, better, best, is it the best? The answer is no. I think a fellowship with Jit would be that would be the gold standard, right? But is there a person in their learning journey in whom you don't necessarily need to go expend that much? Do you need to have best every time? The answer is there are people in their learning journey at all different stages, right? And for some, that might be enough. And we're seeing, for instance, like new surgeons coming out now who have done some anterior through their primary training. So they've actually had experience in this, but they're junior consultants and they just need that little bit of a high hand holding, and then so maybe a visitation and a reverse visitation is all they need, right? So that's a different person.
So Patrick, you kind of raised this question in my mind, and Jit, you had mentioned this before. Is there a role in this type of education, especially on approaches like anterior approach or other more complex procedures, for a no-fly list? I mean, are there people that we should just be able to say, you should move on, mate, just do something else? Or is this a situation where enough time, enough dedication, enough resources, and we're going to get you to where you need to be?
Oh, look, 100%. I think I'm going to step in there and say, look, I have one of my mentors used to say to me, you can't fly like an eagle when you're a duck, right? And it's a horrible expression, but but look, it's a very, I think we all know our abilities, and, I watch some of my senior surgeons who are master surgeons who are beautiful. And I just sit there thinking, oh, look, am I ever going to be like that? Right. And I think we're all pushing ourselves to be better and better. And we know some of us have awareness, some of us don't, but I definitely think there is a higher level of manual dexterity and manual intensity and awareness that you need to do to be able to do that, right? It's a more technically demanding operation, and sort of that's what makes it fun for us. We need a new level of challenge. But on the flip side, it's got lots of, I guess, benefits. I'm going to speak to with technology and training. I went through a lot of things to try to enable this to be better. So I went on augmented reality, virtual reality there's a group called Fundamental Surgery in the UK who've got haptic feedback. So you can feel the incision, feel the osteotomes, feel the broaching. And, I'm one of those people who's happy to accept that my initial belief about COVID was completely wrong. I'm always very happy to accept and go back and say what I did was wrong. And I can say that all of those enabling technologies, which I thought was going to be great, wasn't so good, right? And I think it comes down to something very simple. I think what Patrick said, hopefully it seeps into training enough that it may be that these visitations and reverse visitations is all that's required. And hopefully in the future, nothing at all, but they've done enough training that they don't need to do it.
The real question though is who was the gatekeeper on that, right?
Right.
So if it doesn't matter. I mean, whether they're a trainee, or so if they're a trainee, that's easy, right? Because there's a standard that you need to achieve for you to be able to pass that unit. And if you haven't achieved it, then you require retraining, right? So that's easy. What happens when you've got the ticket? Well, got your ticket, haven't you? Right. So so the real question is, who is the arbitrator of the gate? As who is the gatekeeper? And is that the educator? Because if someone comes to visit me, I can't tell them not to do it. It's like I can give them some really sage-like advice, saying like, watch out, and maybe you might consider a little bit of additional training. But then I think the other thing is that most companies now are quite invested in trying to make sure that their implants are, in Australia anyway, because of our national joint replacement registry, sort of picking up the trends of revisions and failures. Industry has a stake in ensuring that their implants are being placed in by, surgeons who have got a low revision rate. And so it's in their interest to make sure that we're up to scratch, right? So sometimes I might have industry come to me and say, listen, we've got the surgeon who's struggling a little bit. And these are the parts that he's finding hard. He or she is finding hard. Do you mind if we can bring them along so you can specifically nail down how to deliver the femur, for instance, right? And so that's where they come back to be able to learn that one particular step.
Join me next week for the final part of our roundtable discussion, examining the anterior approach from down under. We finish our conversation with guests Patrick Weinrauch, Jit Balakumar, Ilan Freedman, and Joe Scerri. Don't forget to check our show notes for information about each of their practices. Make sure to like and subscribe so we can keep this type of content coming. And until next week, this is Joe Schwab reminding you to keep those hips happy and healthy.